there?
All of them are there, sir.
Oh, yeah. Okay. Can you see my screen?
No, still not.
Okay. One sec. Security of Apple. Is my screen visible now? No.
Yes, sir.
Okay. Thank you. Okay. So the topic is which molecular test do you do for a patient? And Dr. Sachin has given me about 5 tumor types. So based on the time, let's see how much we can go over. So these are my panelists, and Sachin sir, all of them are there. So first question I would like to ask is, molecular testing in cancer, should we do? If all the panel people agree that we should do, we can continue. If you say no, we can close the topic here.
We all say yes, sir.
Okay, thank you. So let's go ahead. I'll just give a brief about why we need to do it, because as Ricky already laid the nice foundation, we're always looking at cancer genes and mutations. There are about 140 driver genes. 60% of them are tumor suppressor genes, 40% are oncogenes, and more than 1,000 driver gene mutations are known today. And most tumors have anywhere from 2 to 10 driver mutations. So this is a very familiar picture for all of you, that we know DNA is the genomic storehouse, but we have taken a long time from knowing this to using this to the advantage for our patients. So let me start with a small trivia. Each cell has DNA. Can anybody tell what is the length of this DNA strand? Okay, it's about 2 meters. Okay, and we have about 100 trillion cells in the body. And if you put the DNA end to end, it is more than 100 times the distance of Earth to Sun. That is, Earth to Sun is 98 million miles. So that is how much of information stored in our whole body. And just to put the whole thing in perspective, it's about 25,000 strands of DNA, if put together, is equal to a single strand of human hair. So this is just to put everything in perspective so that we understand. This is just to tell you that the cancer mortality has definitely decreased over time. This is data from 1930, and this was published this January, showing you that there is a definite fall in both men and women dying due to cancers. And I believe it is because of this, because we're looking at personalized cancer care therapy, we're looking at markers, and that is what this whole panel discussion is going to be about. So this is just to show you some of the major cancers and how it has changed over time. For example, non-small cell lung cancer, there's a nice terminology I found. It was a non-segmented lung cancer. But today, in 2016, we have so many segments that are there. So I would just like to say that from an unsegmented of tumors, we've gone to segmented, and today we are talking of multi-segmented tumors. So I think that is what has been the molecular markers doing for our tumors and ultimately helping patient care. So let's start with breast cancer. So this is just to show you the timelines, how we have progressed. And let's start with a case. There's a 46-year-old lady who was presented with a right breast mass. So she's premenopausal, no relevant past history. She undergoes a lumpectomy with axillary dissection, and the histopathology is IDS, T2N0M0, grade 3, ER plus, 70%, PR negative, HER2 negative. And she has 0 lymph nodes positive. Her tumor is high grade and 1 centimeter in diameter. How will you manage her treatment? Maybe I'll start with Amish here.
Yes, sir.
What would you do next to manage her?
Sir, less than 50-year-old lady, that is a fundamental differentiation. Right. Second thing, she is ER 70% but grade 3.
Yes.
So this is a little dichotomy in this thing. Assuming the grade is high grade,
Yes.
grade 3,
Yeah.
lymph node negative, T2 and 0.
Yes.
I will offer genomic assay, but I would be happy if she decides for chemotherapy, because in both Taylor X and Mindec 8.7 years follow-up data shows that people benefit when in less than 50 years age group.
So I will come to that next. So this is NCI guidelines in 2001. They said adjuvant chemotherapy for any tumor that is more than 1. And at that time we knew that there is benefit, yes, to all, no. Toxicity to all, yes. So that was where we stood. But now we have progressed. So with all these, and as you are talking about, we are looking at gene genetic profiling of tumor. So essentially, we are looking at who can be spared adjuvant chemotherapy, because we do believe, in spite of being medical oncologists, that chemotherapy is toxic. Right, Amish?
Yes, sir.
Okay. Okay. So now Oncotype DX. Now you can take over and tell me a little more about all these.
No, thank you, sir. I think if I understand correctly, the idea of asking the question is which patients genomic assay and where we can spare people.
Right.
That's the whole idea.
Absolutely.
So we have two large studies, Taylor X and Mindec. One is on Oncotype DX and one is on Babu. Both have shown that in an intermediate category, you can avoid chemotherapy if the patient fall into low risk. One is on 70 gene, one is on 21 gene. But both had caveat less than 50 years, patients benefited with chemotherapy, addition of chemotherapy. So anybody more than 50 years, postmenopausal, early breast cancer with low risk genomic assays, clinically low risk, I think these are the patients we should avoid chemotherapy as of 2020 today, sir.
Okay. Jatin, what is your take on this?
Well, I agree with Dr. Amish. Yes, less than 50 years, the patients do benefit with addition of chemotherapy, but for more than 50 years postmenopausal, one can offer these tests if they afford it. And in low risk subtype, we can safely avoid chemotherapy. There is hardly any benefit in that.
Okay. Dr. Aparna, what is your take on this? Because you are slightly on the other side of the fence as far as we are concerned.
No, I completely agree. Based on the trials, it does make sense that if the patient can afford, this would be a good option, these genomic assays.
Dr. Arun, you are from MedGenome. So what is your take on these?
Yeah,
because it is nice to hear from a scientist as well.
Thank you. I do concur with the findings, because the clinical trials are quite compelling to use this, and they are good. The results are good. The prediction rates are also pretty good. So yeah, as of now, this can be used upon.
Okay, Dr. Anuba, what is your experience with this?
We can't hear you, Dr. Anuba.
Yeah, she's there. Okay, as she's coming on, what about Amit? Okay.
I agree with Dr. Amish, what he said.
Okay.
And she qualifies for not to go for genomic assays as of now, because we are not very sure how much benefit we'll give avoiding chemotherapy in this case.
So you don't even want to do a...
yeah, so I would, because it's a quite clear-cut case for us to give chemotherapy.
Okay. So this is just one slide which I took to show in the UK how this use of Oncotype DX has shifted the initial thing of looking at chemotherapy and hormonal therapy, and how it has changed the number of patients from getting chemotherapy into hormonal therapy. So this is just from one country, but there is enough data from several other countries as well showing you the use of this Oncotype DX. I think there are several other platforms that are there. Dr. Jatin, would you like to talk about the other platforms similar to Oncotype DX or differing from Oncotype DX, which you are aware of and there in the market?
There is a platform of ProSigna, which gives its recommendation based on relative risk of recurrence score. We have a platform in India which is IHC based, that is Scan Assist, which we have used in some patients, and that is quite reasonably okay. But it is not part of guidelines as yet. So these two I remember, and the rest are Oncotype DX, Memaprint. One is I think breast cancer index.
Yeah.
Index.
So I found this interesting article from JAMA Oncology. Actually compared the various platforms that are there, and they put out position papers. What they concluded was the clinical pathological late recurrence, genomic assays, all these have shown clinical validation for late recurrences, value above and beyond clinical parameters. But the key facts in decision making is looking at the toxicities for extended endocrine therapy, the absolute reduction with extended endocrine therapy. So these are the things that most of them would answer. So back to our patient now. She got ovarian function suppression plus an AI. Would all of you agree with this?
No.
This after chemotherapy, sir?
No.
Patient did not go for chemotherapy.
Yes, did not go for chemotherapy.
All panelists agreed for chemo.
That's right. But this patient was counseled. She said no. She had heard about some things that you can avoid chemotherapy, that you can do this. So she took this.
So if she has taken this, it can be justified because there's a lot of criticism between 45 to 50 years.
Yeah, that's right.
Whether the effect of chemotherapy was on causing menopause versus the actual toxic effect of chemo.
That's right.
We can justify this step.
In fact, right now there's a study ongoing comparing chemo versus hormone therapy. That probably will answer the question. Okay, so this patient, 4.5 years later, came back with symptoms. CT scan showed numerous lytic lesions throughout the skeletal system, obviously metastasis. Bone scan shows the increased activity in all these regions mentioned. And she underwent a right iliac crest FNAC that showed adenocarcinoma consistent with the metastasis, which means that there is a marrow involvement. So at this point of time, these are the options that you have. What would you do for her?
Should I answer?
Yeah, go ahead, Jatin.
Yeah. So this lady was ER positive.
Correct. Right. Negative?
To negative ER positive. And she has been, she's showing secondary resistance to hormone.
Correct. So 0.5 years later.
Yeah, and if she has been given an AI along with ovarian suppression, I think we can go ahead with this trend with CDK4/6 inhibitor, that first choice, and along with goserelin.
Right. So in fact, that's what she got, but some of this is getting highlighted. She got fulvestrant plus CDK4/6 inhibitor, and which she took for almost 14 months. But at that point of time, she came back with increasing back pain, and the PET scan at this point of time showed metastasis in liver, lungs, and bones. And even by age and the therapy that she had become postmenopausal by this time. So what would you do next? Amit?
Yeah, I would like to have the MGS right now on the patient to see what are the reasons for resistance, and if I can use
any specific thing you want to look for at this time?
PIK3CA is my potential target here.
Okay, so this is the recommendation from the guidelines talking about how you do PIK3 mutation. So this patient.
Sir, I have a small suggestion or a comment.
Yeah.
The PIK3CA based on this SOLAR-1 trial has been approved with fulvestrant.
Correct.
And in this patient, my question is, should we use PIK3CA? Now it is available PCR-based method also. Should we use it before we use CDK4/6 so that we keep our fulvestrant option open? Or should
brought up? In fact, this was discussed at one of the meetings of PIK3CA inhibitors. And what happened was the CDK4/6 inhibitors came in first. But in some places, these two came at the same time. So some of them have been using alpelisib even before CDK4/6 inhibitors. But they found the toxicity of alpelisib to be little high. And they found that in limited number of patients, whether you use alpelisib first or CDK4/6 inhibitors first, and then you use the other, the responses are very similar. So since the experience with PI3CK inhibitors is still limited, so most people do believe that you go ahead and use CDK4/6 inhibitors and then use the PI3CK inhibitors.
True.
And the PI3CK mutations are very stable. So even if you have done it on the initial archival tissue, even now it will not have changed. So that is negative.
And you can reuse aromatase inhibitors with PIK3CA mutation.
No, sir, I'll tell you why my point was that in a bone-only limited disease, now she has liver plus lung, but in a bone-only liver limited, this fulvestrant plus alpelisib have shown to be beneficial because fulvestrant also works in bone only.
Correct.
My point was, going in future, we'll get these dilemmas every day.
Of course.
Should we keep her fulvestrant for alpelisib, PIK3CA, and use another hormone before we use? That was the question, sir.
In fact, there is retrospective data for fulvestrant use. They have said using it earlier lines, the responses are better. So that is another thing, confounding factor that will come up.
Right, sir.
So we still don't know all the answers.
We don't know.
Yeah. So this is just about detecting it in tissue or plasma. And again, the lesson that we have learned from T790M mutation, doing it on liquid biopsy and holds good for the PI3CK mutation as well. So you can do it as a liquid biopsy, and if that is negative, then you need to try and get the tissue. If it is positive, you can use your therapy based on the liquid biopsy itself. So this patient was started on alpelisib, and we continued the fulvestrant. Because like Amish said, that is what is the good thing. So I think she is ongoing treatment for this, so we will stop. So this is the proposed algorithm. In those patients who have no visceral crisis. So this is going to actually change. So even in visceral crisis, we will soon get evidence to say that you don't really have to use chemotherapy up front. Okay. Now back to the same patient. This is still hypothetical. Everything same. She is HER2 plus now. So Jatin, what would you do?
Yeah, so she requires the chemotherapy along with the anti-HER2 new antibody. Even though she is node negative, but she is grade 3, so T2. So I would give full one. Okay.
So this question is, do you consider HER2 as a predictive or prognostic? Dr. Anubha, are you audible now to us?
So can you hear me now?
Yes, go ahead.
Finally.
Sorry, I'm on my phone now.
No problem.
I think in today's era, it is definitely predictive because we will be selecting our treatment based on, because she's HER2 new positive.
Yeah.
And I would say, I'm not sure that I would completely agree with prognostic, because in today's era, such a patient who has a small, the size of the tumor, even if she's HER2 new positive, she has a 95%, 90 plus survival.
Correct. So this is just to show you that when trastuzumab came in, or just before that, overexpression of HER2 was associated with poor prognosis. So it is a prognostic, and this is to show you that it is predictive also. So this is the NEJM paper of Dennis in 1999, who showed the advantage of using trastuzumab. So what about adjuvant trastuzumab? Who would like to take this? Yeah, Anubha, go ahead since you're audible now.
So for this patient, I would use paclitaxel plus adjuvant trastuzumab.
Okay.
The weekly.
So we are not going to discuss the chemotherapy part because we are talking about molecular markers. So so trastuzumab. So this is the data. Of course, this is an old slide now, 2006. But even at that point of time, we had these 4 last trials. We should have accrued over 13,000 patients to show you that using trastuzumab in that adjuvant setting was in fact beneficial. This is one interesting slide I thought I'll just show. Again, this is an old slide, 2008. So this is showing you that how many patients were actually benefited in absolute numbers. Almost 27,000 patients from 2005 to 2015 benefited from in preventing recurrences when trastuzumab was used. Any comment on this, Amish?
Also,
In fact, this was interesting data, so I just thought I'd put this up.
very interesting, sir.
Yeah, really. So, okay, breast cancer genomic analysis. So we are talking about trastuzumab use.
Can I just very
Yeah, go
quick
ahead.
comment? So there was ASCO 2020, there was a very interesting article which was a paper which was published, was Monarch Earth. So this particular patient, if he relapses, you can use CDK4/6 with HER2, and they found that patients do very well. So in fact, delaying chemo further and further, since we are talking of molecular targets, I thought that that is something very interesting paper.
Yeah, I think all these hormonal therapies and targeted therapies have actually, brought about this concept of delaying chemotherapy for our patients. You preserve their general condition and you prolong them to such an extent that you can reserve your chemotherapy for later lines, preserving the quality of life and general condition. True.
Nowadays,
So this is
nowadays low HER2, this concept of low HER2 positivity also comes. So there are antibody drug conjugates who check and HER2. That is also interesting.
Yeah. So, are there any gene signatures for response prediction to anti-HER2? Let's ask Dr. Arun Kumar, since he's from the lab. Dr. Arun? Gene signatures?
Yes.
Yeah, go ahead.
Yes, say for HER2 resistance, there are a few mechanisms such as, overexpression of HER2, one thing. The other is mutations in ERBB4 or ERBB3 genes. And they are one of the mechanisms by which resistance for HER2 therapy is coming.
So this is one paper, actually, this is an abstract only, which looked at 32 genes in 372 breast cancer patients, and they showed a 5-year relapse-free survival with a p-value of 0.001. This was a paper presented by Dr. Edith Perez in San Antonio. But I have not seen the full paper of this, so I really don't know how it has been gone forward. Okay, we'll look at PI3CK mutation in HER2 positive disease.
Yes.
Yeah. And why would you do that?
It confers the resistance to HER2.
Yeah. So this is a paper that I got talking about mutations which blunt the response to anti-HER2 therapy. And these are all the studies which have shown that this is in fact true. Of course, this is all retrospective data, but it was prospectively collected for PI3CK mutations.
In the absence of any data benefiting addition of PIK3CA inhibitor like alpelisib, these are all only prognostic markers.
Correct.
PIK3CA positive will not respond well to chemo, also will not respond well to anti-HER2 also.
Correct.
But we do not have any combination of anti-HER2 with alpelisib right now.
Absolutely.
So I think it would more of a research product rather than must in clinic.
Correct. That's why I put it towards the end of our discussion. So this is just to stimulate your thoughts. So I think with that we'll complete breast cancer. Let me go on to non-small cell lung cancer.
So we have about 3 minutes.
Oh my God!
There was some significant point you want to,
Oh my God! That only one tumor. Like I told you in the beginning, I don't know how many we can do. Okay. This is lung. This is a 63-year-old lady who I saw in 2008. She had EGFR 19 exon 19 deletion. She was in gefitinib and she responded well. But as usual, 14 months, they do show resistance. What we'll do next, I think this is all everybody knows now. But if you had seen her in 2020, what would you do? Amish?
The gefitinib alone is now a pass of the past. So either if the patient...
No, we are talking about molecular markers now, forget the treatment.
Molecular markers, if the patient can afford, if the tissue is available, NGS is the way to go for.
Okay. So this is the new taxonomy for metastatic non-small cell lung cancer. We're looking at everything that is possible put up on this slide. And as you heard from the previous talk, NGS is the way to go about to do this. Tissue versus liquid biopsy, we discussed this in breast. In lung cancer, again, we have data from looking at EGFR. This is for objective response and PFS showing you that either you test in the DNA or in tumor type, tumor tissue, your responses are very similar. So also for T790 mutation. So that is an established role that can either do liquid biopsy or tumor tissue. And this is the targeted therapies that we have today. Therefore, NGS is the way to go about to do everything. Since we don't have time, I don't think I can do the next 3 tumors. So I think we'll stop with that. And I would ask each one of my panelists to give some final comments. Amish, you can start.
Thank you, sir. Since I have spoken the most, I would like other panelists to speak about.
Okay. Arun Kumar.
Yeah, hi. I would like to just emphasize upon one practical difficulty we as a laboratory face.
Yes.
The quality of the FFPE block, number
Yes.
one, and the amount of tissue available.
Yes.
So if NGS is done upfront, the amount of tissue available is also more, and the age of the block is also less.
Correct.
So these do certain things that, especially in the Indian scenario, we find that the quality of the formulary used is pretty bad.
Yeah, it is
And
not buffered formalin. Yes.
Yeah.
So we've been taking classes with the pathologist now. So they are also sensitizing everybody, including the intervention radiologist and the pathology lab, as to how they need to really process the tissue. And I think it's getting better. And as medical oncologists, we are very well tuned to getting the extended panel upfront. So I think that's okay with us.
That's
Dr. Anupam?
that I would like to make.
So I think this is something in progress. Like in non-small cell lung cancer, we have understood that NGS is the way to go. But I wouldn't completely agree for the other tumors such as breast, etc.
Agreed.
And I think as the future, as in the future, we will probably know more how to understand and use these use NGS in other malignancies and understand the mutations, and then
Since you're running a molecular tumor board, what are your thoughts?
I would say that whenever you encounter something unusual in your response to the treatment, or you have early failures, I think NGS should come handy. And sometimes you get quite good answers, and which will be beneficial for the patient as to be early run, actually.
Yeah, I agree.
That's
So
my take on it.
ultimately, I think you need to be a good clinician and not just depend on what is there. If you find that your patient is not responding the way you expect them to respond, intervene immediately and look for what else you can do best. Yeah, that's a very good point. Dr. Aparna, your final comments?
No, I agree with the panelists. As and where we can use NGS, it is an absolutely brilliant platform. It doesn't always have to be one of those extensive large panels. It can be something even small, which is organ specific. Another comment that I also agree with Dr. Arun. We do tend to face this issue in the lab where we don't get good quality of, unfortunately, blocks, and then we have the very awkward conversation of calling a physician and saying tumor assumption, or poor DNA quality. So I do agree with that. But the one point that I want to highlight is that in a lot of cases, we are starting to see a trend where unfortunately people are getting diagnosed under the age of 50, and like we saw in this case, the breast cancer. And I would urge everyone, please do send them in for hereditary testing, because while it may not be of much help to the patient diagnosed, you could possibly prevent or help manage the rest of the family.
Yes, we have time for ovarian cancer, otherwise we were going to discuss that. Okay, these are the last 3 slides. I must show them because I made these slides recently. So this is how our OPDs used to be in 1990 when I started. Medical oncology, surgical oncology, radiation oncology. But it's programmed to breast oncology, thoracic oncology. But what I see in the future will be EGFR oncology, HER2 oncology, BRAF oncology, BCR-ABL oncology. So that's how I see it. So in conclusion, cancer therapies from empirically determined therapies would go extinct like the dinosaur way, and molecular-based therapies are there to stay to bring about a nice rainbow to our patients. So with that, I will stop. Sachin, thank you.